Hello and good morning. Thank you for joining us for our Facebook Live question and answer session. My name is Dr. Barham Abu Dayyeh and joining me is Dr. Andres Acosta. Today we are talking about endoscopic sleeve gastroplasty, what it is and what it does. Throughout the broadcast we will be taking questions, so please make sure to post your questions in the comment section below. Dr. Acosta, thank you for joining me. Let's start off conversation by talking about the spectrum of obesity care in the United States.
Yeah, Dr. Dayyeh, thank you for doing this session with me. I think I'm terrific to be here talking with you about this game changer for obesity management. When we talk about obesity management, as we can see in this slide, we have many options, many good options actually. We have on one side of the spectrum with very low risk, things like our Mayo Clinic diet experience or our healthy living programs, which basically focus on lifestyle medications. Mm-hmm. Then we have with a little more risk, but a little more small benefit, medications. And then we go to the other spectrum, bariatric surgery. Mm-hmm. Bariatric surgery, you can lose a lot of weight, it's successful, but it comes with a lot of complications. And we know it's a major surgery, long-term complications, minerals and vitamins deficiencies that we have to watch for life. So what we have envisioned, and you and many others pioneer on this, is these endoscopic procedures. Mm-hmm. And the one that we want to talk today is this endoscopic sleeve gastroplasty. And I'll let you explain this more detail, but this procedure fills the gap between less invasive procedures with minimal on some benefits and more aggressive procedures in which they have a lot of benefits but also a lot of risk. Mm-hmm. So these procedures by endoscopy, meaning no sutures, no scars, fills that gap, and patients can benefit from a long-term sustained weight loss that is very less invasive. So could you tell us more? You were one of the pioneers in developing this technique that now has been adopted by most of the world and is kind of the hot thing in obesity management, and we have been seeing great results. Could you explain us more about this procedure?
Thank you, Andres. As you alluded, this procedure was pioneered in humans at the Mayo Clinic starting in 2013 with Dr. Christopher Gestout and myself, and you joining us along with Dr. Camilleri. And the whole idea is to find a gap between non-surgical and surgical management of obesity. This is not surgery, it's endoscopy. That means the whole procedure is done through your mouth. It's an outpatient procedure. The recovery period is quick, and the safety margin is also very good. So that means this is a tool to allow patients to get significant weight loss results, more than diet, exercise, or medications alone. But it's less than surgical weight loss, but it's in between. And the idea is we are giving patients the opportunity to empower themselves to lose a lot of weight without all the risks that comes with surgical intervention. Therefore, the people that this should be targeting are those people who have anywhere between 10 to 50 pounds to lose. If you have more than that, surgical options are more effective. Mm-hmm. If you have less than that, starting with lifestyle interventions alone is enough. And this is the gap that these interventions like the endoscopic sleeve gastroplasty are filling. So let's look at a video that we have here about the procedure to illustrate how it's done. The procedure basically is done through the endoscope. It's a camera that goes to the patient's mouth, and we use a new development within endoscopy, which is a suturing machine or a sewing machine that allows us to put sutures within the gastric wall or the stomach wall and shrink the size of the stomach from a sack or a big bag to the size of a banana, basically. And that does two things. One, it restricts the amount of food you could eat at one session because your stomach now is about 80 to 90% smaller than it was before. And number two, it seems to delay the rate by which food is emptied. That means you could eat a small meal, and that meal would last you for a longer time, so you feel satiated and you have enhanced satiety for a longer period of time. However, we've been there with multiple interventions for obesity, and we know that there is no cure for obesity. Like diabetes, like high blood pressure, it's a chronic disease. And we though now, unlike before, we have many tools to manage this chronic disease. We know that there's no one intervention that will cure the disease. With that in mind, what did we do at Mayo Clinic to enhance the weight maintenance, which is the key component of the weight loss that comes with this procedure?
Correct. So exactly. So the endoscopic sleeve gastroplasty is a great tool. We're having great results, but we're a strong believer that this tool, as many others that we have here at Mayo Clinic, has to come together within a multidisciplinary team. And at Mayo Clinic, we are known for our collaboration and working together to serve the patient interests. And the patient is the first thing that we care for. So we have worked together to put probably the best of the best team of experts in each of these areas. So we have a group of gastroenterologists, such as us, and advanced endoscopies that can do these procedures. We have a group of endocrinologists, experts in obesity. We have a group of dietitians. We have a group of nutritionists, wellness coaches, physical therapists, exercise physiologists, bariatric surgeons, and so on. We have a very multidisciplinary team. If we can put the next slide, we have these what we called the health. It's healthy eating, active lifestyle through habits. So what it means is that when patients come to Mayo Clinic, they meet this multidisciplinary team, and they go through our healthy living program experience. We put the next slide. The healthy living program is our state-of-the-art facility, brand new, beautiful. We offer the best of the best in care. The patients will come to visit us at Mayo Clinic, and they go through our healthy living program. They take advantage of the healthy clinic, Mayo Clinic diet, and they have a personalized healthy living program, which they have their own coach that will walk with them through this process. We introduce the tool of the sleeve gastroplasty, and then we have a comprehensive evaluation physical fitness plan and a team of experts that will walk through this whole program with patients. Because as you well said, obesity is a chronic disease. And we need to have these constant, reliable tools and resources in order to be successful in the long term. So with that said, could you explain us a little more about this procedure? What are the expected outcomes when you adopt something that is sleeve within this multidisciplinary program? And explain us more about the procedure itself as well as what we're expecting within our multidisciplinary program.
Yeah. I mean, we can't emphasize that point enough, Andres, is this procedure, as to any other procedure, is a tool. So if patient gets this procedure, they could expect to lose anywhere between 15 to 20% of their total body weight loss within a short period of time. And within a short period, I mean 3 to 6 months, they expect to see the significant weight loss.
So just to interrupt you there, so someone who comes with around 220 pounds will lose somewhere around 30 to 40 pounds.
30 to 40, sometimes
Okay.
50. The average is about 40 to 50 pounds with
Perfect.
this procedure.
Perfect.
So that means in a short period of time, we took somebody and we have them lose a lot of weight. They're feeling well. And now it's the time to switch strategy. The strategy is you lost a lot of weight. Now the fight is to keep it off. That's why we really had to partner with this multidisciplinary program. We had to go to the Healthy Living program, which is a unique thing at the Mayo Clinic. It's based on solid principle of the Mayo Clinic diet. And it's based on not everybody is gonna follow the same recommendations. That means people have different lifestyles, they're busy, they're different commitments. So we can't just tell somebody, okay, now go diet and exercise. We have to coach them through the process. And that's what the Healthy Living program does. It personalizes the maintenance plan around your schedule.
Correct.
So we work with you to find out when you could exercise. We work with you how to cook, how to buy food, and how to interact. So somebody who follows this principle of a weight loss procedure like the endoscopic sleeve gastroplasty, lose 40, 50 pounds. Now you're feeling better. You have a coach to support you and teach you how to maintain it. They should expect to keep this weight loss off for a very long time. The key is engagement. There's a tool to empower weight loss, but then there is a weight maintenance plan to follow to follow with that. That being said, is this procedure for everyone? Who should be considering this procedure? Could you tell us about this?
Yeah, so when we try to select the best candidates for this procedure, it's important that we have patients who are committed and understand that any intervention, medications, devices, this type of endoscopic procedure or surgery is a tool, as you well said. So the next thing to select is we follow the criteria of body mass index or BMI. So usually we have a BMI above 30 is what is considered obesity. In Southern populations, Hispanics, Asians, 27.5 should be considered obesity. And if you have a comorbidity, you're even a better candidate, something like hypertension, diabetes, high cholesterol. So if you have a BMI above 30, you are a good candidate for the endoscopic sleeve gastroplasty. And we have had great results with that. In contrary to something like surgery, that you need to have a BMI above 40 or a BMI above 35 with comorbidities. So if you guys on the other side of the screen are thinking, what's my BMI? It's very easy. You can go to Mayo Clinic, the webpage, and look at BMI and calculate your BMI based on your weight versus your height. And then you can see if you can qualify for a procedure of that as this. And it turns to be a great tool because you don't need to be as heavy as you need to be for bariatric surgery. So this can target that population that falls in, again, in this gap in which they might want surgery, but they don't qualify, but they still want to lose weight because of their comorbidities or other reasons, and they're heavier for medications.
Which fits it perfectly with a question from a viewer: is there a weight limit on when the gastric sleeve won't work, or it will become too risky? And the answer is, the group of people we're trying to target are those who have anywhere between 10 to 50 pounds to lose. That means would put them in the category of BMI 30 to 40.
Correct.
Because these, we could think, with this procedure plus a healthy living plan, we could get them to a whole different class of the obesity classification.
Right.
And we think we could have impact on health. It doesn't become risky if we offer it to people with higher BMI, but it becomes less effective, in my opinion, because if you have more than 50 pounds to lose, you're better off having one of the effective surgical options that we know that would produce this type of weight loss. So to answer directly the question is, the recommendation here for this procedure is people with body mass index between 30 to 40. If you're on the above 40 category, then our recommendation would be bariatric surgery. What do you think about these recommendations?
I completely agree. I think that's a way to see what you need to gain from a procedure, and the 30 to 40 is probably the ideal. The only thing I can add about that is sometimes patients who are very heavy, and I don't know, that's where they might need a bridge procedure. And what I mean by a bridge procedure is a less aggressive procedure in which there is minimal risk to do the procedure, like the endoscopic sleeve gastroplasty that we're talking today, in which is a 45-minute procedure, outpatient procedure is very quick. And patients who are very heavy can rely on a procedure like this, acknowledging or understanding that this is only going to be a bridge, maybe to consider another procedure down in the future, something like surgery. But we rarely do this type of approach. We prefer to classify them into the BMI of 30 or 40, you said, and leave patients with a BMI above 40 for bariatric surgery or a more aggressive intervention.
Absolutely, and I think you're right. I mean, bariatric surgery is an effective and safe option for those with body mass index above 40. However, not everyone is comfortable with the concept of surgery.
Correct.
And there's barriers to kidding surgery sometimes, whether it's insurance coverage or other things, which we cannot, just beyond the scope of discussing today. But for those who do not wish to proceed with bariatric surgery or cannot get bariatric surgery, the endoscopic sleeve becomes an option, but we have to know that we have to be very aggressive with the lifestyle intervention around it. So it's not the standard option, but it's not too risky to have it if you're above 40, but we have to set reasonable expectation.
Correct.
What to expect with the procedure in that group of people of patients with this body mass index.
Correct.
You do a lot of physiology. You know how we humans regulate our appetite, and how and what happens when we are trying to diet.
Correct.
And we know that we try to diet, we are committed to diet, but then we go on a restrictive diet. That means we're following low calories every day, and at the end of the week we're miserably hungry, and we tend to overeat, and we go into this yo-yo diet that ends up with weight regain in the long term. How does procedures like the endoscopic sleeve gastroplasty work to disrupt these hunger signals?
You know, Dr. Willie, I discuss this with my patients all the time. Well, unfortunately, when we are dieting alone, our body is kind of fighting us back. It doesn't allow us to be successful. Why? Because of many reasons, but the most important is we have hormones, such as insulin, that many of you have heard of, cortisol. There's a hormone called ghrelin, our appetite hormone. This hormone, every time we go into a diet, goes way high. So it makes us so difficult to stick to the diet because we are starving. The hormone goes high, we're so hungry, and it's very difficult to stick to the diet. Everyone is very disciplined, is trying to follow the diet, they understand they need to lose weight, they want to lose weight, they're trying very hard, but they cannot fight our body. They cannot fight our own physiology. So what we need to do is use these tools, like the sleeve, that what it does when it restricts down the stomach and brings it to this banana-sized stomach, as you clearly mentioned, it will reduce this type of hormones, such as ghrelin, and then when we try to diet, it will not go so high, so we can actually stick to the diet. That's why we call it a tool, because help us fight back. So it produces that restriction of the stomach, so we can feel full also with less calories, and then also delays the time of the food coming out of the stomach, and there's data coming from your lab, that delays how the food comes out of the stomach, so the food sits longer on the stomach and we feel full longer. So there's many reasons behind how exactly this works, and unfortunately, why diets alone don't work. And that's why we, as experts in the field, tend to recommend not only these tools, but many of the tools that we have available for those patients who have tried a diet and exercise program and are not being so successful. And that's why I think the benefits, and you can tell us a little bit more about this, what are the benefits in the long term? What have you seen in your initial studies since you were doing this since 2012? What have you seen in the long term when we use this type of tools?
We see good things if the patient is committed to this multidisciplinary approach. We know for a fact, if you have 40 to 50 pounds to lose and you lose them, your diabetes is going to significantly improve. If you're on diabetes meds, there's a good chance you might be off the diabetes meds. We know your high blood pressure will also improve, and you could go off the high blood pressure medications. What we also know that if you are having 40 to 50 pounds to lose and you have history of diabetes, your chances, or in your family, your chances of developing type 2 diabetes is reduced by at least 80% in the coming 10 years if you lose the weight and you keep it up. So there's a lot of health benefits, and we just mentioned a few here with this kind of weight loss. But the key is we're going to partner with the patient. We, over the past 3 to 4 years, we spent hours and hours and weeks developing this program, partnering with the state-of-the-art Dan Abraham Healthy Living facility in order to do this combined program where we empower patient with a procedure that produce significant and quick weight loss and give them the tool to maintain it over the long term. Any people who should not consider a procedure like endoscopic sleeve gastroplasty? We talked about the weight limits, but what about surgical history and stuff like that?
We tend to prefer to stay away from patients who have had gastric surgeries in the past. So if you had any reasons why you had your surgery in your stomach, tend not to be a good candidate. Right now it's controversial, and we'll have to assess on an individual basis those patients who have large hiatal hernias or other problems in the stomach that might tend to.
Could you clarify for our viewer what's a hiatal hernia?
Yeah, hiatal hernia is when a part of your stomach goes beyond your diaphragm muscles into your thoracic cavity, and that tends to be associated with acid reflux. So when we see those type of patients, we tend to, but we analyze that on an individual basis based on their size of their hernia.
And some people don't know they have it, so we always look and we make our decisions. Small ones, we could still do the procedure. Larger one, we can't do the procedure. Now, as far as recovery, expectation, diet after the procedure, any words of wisdom that you could give our viewers?
You know, we see our patients every day, the day after the procedure. So just to make an emphasis, this is an outpatient procedure. So the patient comes, they come to our endoscopy unit. Within 45 minutes, the procedure is completed, and then they go back to their home. We tend to see them the day after. And the majority of patients are doing well. Their pain is well controlled with medications.
How long does this pain after the procedure usually last?
Usually lasts a day to two.
Okay.
So it's a quick recovery, and it's a pain that allows patients to be functional, allows patients to be okay, maybe a little bit of nausea that is well controlled with medications, and usually very well and safe and tolerated the procedure. To the point that most of our patients within 48 hours to 72 hours are back to work. So they don't need to take a whole week. Usually we plan to do this on Thursday or Friday. So by next Monday they can return to work. So very need to take time out of job, which is important because most of our patients are working. And then after that, the patients recover completely. And what we do is we put them on a diet. And that's something we haven't talked. We put them on a liquid diet for a whole month. And there's an important reason for that is because we want to stay on a liquids in order for allowing the stomach to really form this banana-sized stomach and prevent it from the sutures from giving up. In your initial studies with Dr. Chris Gastout, when you went back to see it, you saw that those patients who stick to the liquid calories did the best. And it's a great way to be compliant with the diet. And within a month, they are back to their regular healthy diet that we come up and discuss with the dietitians and the coaches. Can you tell us a little bit about the safety of this procedure in our experience as well as in others' procedure experience?
Before we talk about that, so there's a question, which is an important question from one of the viewers. Is this procedure, endoscopic sleeve gastroplasty, the same as gastric sleeve? And it's thank you for the viewer who asked this question because that's an important distinction. A gastric sleeve procedure is a surgical procedure where the surgeon uses cameras that are inserted in your abdomen in order to cut part of the stomach to create the sleeve. So it's not the same. What we're talking about here is an endoscopic option where there is no surgical scars or surgical incisions. We go through the mouth and we use a sewing machine in order to fold the stomach on itself in order to restrict its capacity. So at the end of the day, it looks similar, but they're completely different procedure.
Correct.
One is surgery, the other is not surgery, and one does not cut your stomach, the other cuts your stomach.
Correct.
So it's very important to keep this separate.
And one is inpatient, and the other one is outpatient.
Absolutely.
I think it's important.
So we have a few more minutes left here. It's worth discussing the expectation for the program. If viewers out there saying might be appealing to me, I would like to do it. Here again, we ask patients to prepare themselves to be in Mayo Clinic in Rochester for a whole week because we have this healthy living program, and it's almost a boot camp. The first 2 days of the program, you have a full multidisciplinary team evaluation with psychology, nutrition, exercise physiology. We do some measurement on your body composition, muscle and fat. We tailor a plan of eating, plan of buying groceries, plan of exercising, and you leave these 2 full days from the Dan Abraham Healthy Living with this program. Day 3, you get your procedure. Day 4, we see you in clinic. If everything is good, we put you in touch back with your healthcare coach that's assigned to you, and off you go for the next 12 months of this intensive coaching program to help you lose the weight and maintain it. Any final departing words of wisdom here?
Well, I think on the screen you can see our phone number if you're interested in making an appointment. I will be happy to see you in the clinic and discuss this. We know that many people will be interested. Also invite them to visit our webpage. We have many of this information with videos and more information, as well as other broadcasts that we have done and YouTube videos that has a lot more information. And you can hear the comments not only from us, but our patients as well as other perspectives.
So it's time to wrap up. That's all we have time for today. Thank you for joining us today for our discussion about endoscopic sleeve gastroplasty. The discussion will be on Mayo Clinic's YouTube channel for future viewing. If we did not get a chance to answer your question, we will try to do so after the broadcast. Thank you and have a great day. Thank you, Dr. Acosta.
Thanks, Dr. Dayyeh. Pleasure to be here.